Hello, my name is Kathleen Liu. I'm a professor of medicine at the University of California, San Francisco, and today I'm delighted to present to you on the topic of fluid management in renal failure. I have no conflicts of interest that are relevant to the content of this presentation. So first, why is this an important topic for us to discuss today? We know that volume resuscitation is a cornerstone of critical care management. As shown on the left, we can see that patients enrolled in a clinical trial of septic shock received an average of approximately 7 to 8 liters of fluid over a 72-hour period. Thus, the opportunity for volume overload is very common. In addition, we know that kidney injury or renal failure is a common condition in critically ill patients. And this has led to the proposal, for example, for volume management, that patients may undergo a period of volume rescue followed by optimization, but there needs to be additional fluid management to remove the fluid that we often must give to our patients early on in their care. We know that a fluid conservative strategy is beneficial in patients with the acute respiratory distress syndrome after the resolution of initial shock. This is data from the FACT trial. You can see here that patients treated with the fluid conservative strategy had an approximately even fluid balance over the first 7 days of the trial compared to patients in the standard fluid liberal arm who had an approximately 7-liter positive fluid balance over the same time. This resulted in a statistically significant difference in the number of ventilator-free days, with better outcomes in the patient in the fluid conservative arm. This was very statistically significant. However, one of the challenges to the interpretation of this study in our patients with renal failure is that per protocol, diuresis was held if renal failure was present. This was defined as either dialysis dependence, oliguria with a creatinine greater than 3 milligrams per deciliter, or oliguria with a creatinine between 0 and 3 milligrams per deciliter, with urinary studies indicative of acute renal failure, but with relatively little guidance as to what would constitute such urinary studies. So how do we manage fluid in patients with renal failure? I think this is a $10 million question, or at least a $1 million question. First, I want to make the point that diuretics are not all bad in patients with renal failure. I'm going to show you data from 2 studies to support this comment. First, this is a clinical trial that was performed in patients with established acute renal failure of high-dose furosemide, now almost 20 years old. This study, the rationale for the use of furosemide in patients with acute renal failure is that furosemide decreases sodium transport in the Henle, which decreases metabolic demand. The metabolic demand of the kidney is already very high, as we know. The oxygen tension in the medulla of the kidney under normal conditions is only 10 to 20 millimeters of mercury, so this will fall even further under pathologic conditions. In this clinical trial, patients were treated with relatively high doses of furosemide, 25 milligrams per kilo per day, in patients with AKI requiring renal replacement therapy. And although these patients achieved greater urine output, there was no decrease in the time on renal replacement therapy or the time to achieve a threshold creatinine off of renal replacement therapy. That said, this was a safe intervention in these patients was not shown to have significant complications. Along the same lines, the furosemide stress test has been used for risk stratification in patients with acute kidney injury. And here the rationale for this test is that the ability of the kidney to respond to diuretics may have important prognostic value. This is a functional stress test like stress echocardiography in the context of coronary artery disease. So per this protocol, patients receive furosemide at a dose of 1 to 1.5 milligrams per kilo in patients with early acute kidney injury. Urine output is followed and can be used as a prognostic marker for whether or not these patients will have progression to dialysis requiring acute kidney injury. An important point about the furosemide stress test is that you must avoid hypovolemia, and so patients can receive fluid back if they have very brisk urine output. But the bottom line is that the furosemide stress test is safe. It can be used for risk stratification in patients with acute kidney injury. So it is reasonable to give diuretics in certain circumstances to patients with acute kidney injury or acute renal failure. With regards to fluid management in patients with renal failure, we do know that fluid overload is deleterious in these patients. This is a concept that started in the pediatric literature, where fluid overload at dialysis initiation is associated with increased mortality. And it's possible to essentially measure fluid overload as a proportion of increase in body weight. Commonly in the literature, fluid overload is defined as a greater than 10% increase in body weight. It's been shown in pediatrics, as I mentioned, and also in adults that fluid overload is a risk factor in death in patients with acute kidney injury. This is data from a 5-center US study published by José Bouchard and colleagues demonstrating the cumulative probability of survival is lower in patients who are fluid overloaded compared to patients who are not fluid overloaded. And this relationship holds across degrees of fluid overload. I do want to point out that we do need to keep in mind that there are some problems with observational studies of fluid balance. Like this, though, the increased mortality may be related to fluid itself, but may also be related to differences in provider process of care characteristics, comorbidities, and potentially, as I'll show you, lack of recognition of acute kidney injury. From the same study, Ravi Mehta and colleagues have shown that fluid overload is an independent risk factor for sepsis after acute kidney injury. What you can see here is that examining risk factors for sepsis after acute kidney injury, not surprisingly, factors such as immunosuppression and steroid therapy and the need for invasive procedures and higher severity of illness are associated with are independent risk factors for sepsis. But in addition, you can see here that fluid overload in and of itself is a risk factor for sepsis after acute kidney injury. A fluid overload in patients with acute kidney injury may also delay recognition of acute kidney injury. You can apply the similar equations to calculate either a crude serum creatinine or a serum creatinine adjusted for fluid balance. You can see here in this representative data that in a patient who is 6.5 liters positive, that the creatinine, the creatinine adjusted for the increase in volume of distribution is consequently much higher, and you can see that consequently creatinine is underestimated under conditions of fluid overload. And we have applied similarly such a strategy to data from the FACT trial to examine patients in 4 buckets, essentially patients who do not have AKI regardless of whether you correct creatinine for fluid balance, patients who have AKI regardless of whether or not you correct creatinine for fluid balance. And in the middle, there are 2 different groups here. There are patients who do not have AKI. If you do not correct creatinine for fluid balance, these patients are very fluid positive. So when you correct creatinine for fluid balance, you can see that the corrected creatinine is much higher, and these patients do have AKI after the volume correction. Similarly, you can have patients who undergo diuresis, which is well tolerated. The creatinine goes up, but the corrected creatinine, when you account for the change in volume of distribution, does not go up, and those patients do not have AKI if you account for fluid balance. And what you can see here is that if you examine outcomes in these patients, the mortality of patients without AKI, regardless of the way you consider creatinine, is quite low at approximately 12%. Those patients have a relatively high number of ventilator-free days. Again, the more ventilator-free days, the better the outcome. In contrast, patients with acute kidney injury have high mortality, low number of ventilator-free days. And what you can see here is that patients who do not have AKI before you correct for volume overload but do have AKI after you correct for volume overload have high mortality, similar to the patients who have AKI regardless of definition. And the patients who had AKI before you corrected for volume of distribution and when that AKI disappears after you make the fluid balance correction have relatively low mortality and a relatively high number of ventilator-free days. So again, fluid overload or fluid balance in patients with acute kidney injury may impact their ascertainment and outcomes. So finally, how do we manage fluid in patients with renal failure? I think this is an area under construction. There's much more research that needs to be done in this area. I think an important lesson is to avoid intravascular volume depletion. We need to use fluids, as you can see here, but we need to use them cautiously. We need to use a spray bottle, not a large watering can, but optimizing fluid, intravascular fluid, may be an important point for these patients, in particular with renal failure. And the goal when we think about fluid removal in such patients is to mobilize fluids either with diuretics or renal replacement therapy without causing intravascular fluid depletion. This slide is in here to remind us that total body fluid is the combination of intracellular fluid, extracellular fluid, and the extracellular fluid can be both in the interstitial space and in the intravascular space. And as fluid is removed, we hope that we can promote the removal in a patient with total body volume overload. We want to promote the removal of extracellular fluid, but that fluid has to get from the extracellular interstitial space into the intravascular space and then out of the patient. And there are a number of reasons, including low oncotic pressure and the systemic inflammatory response and high cytokine levels, that can make this barrier between the interstitial and intravascular spaces quite leaky, and it may be difficult to promote fluid recruitment into the intravascular space. So in terms of best practices for fluid management in the setting of renal failure, I would recommend that you set goals, but these goals need to be reassessed on an ongoing basis. You cannot let a 24-hour period go by. This may be an hour-to-hour or an every few hour assessment. If you're unable to achieve the goal you've set, for example, diuresis, you need to ask why. Is the patient getting sicker? Is their renal function getting worse? Is the patient relatively intravascularly volume deplete? And is it challenging to recruit fluid from the into the intravascular space for fluid removal, or is the patient getting more fluids in than you had accounted for in your initial plan for patient management? So to summarize, over the past few minutes, I've shown you that in critically ill patients, fluid overload and acute kidney injury are common conditions, that diuretics are not always bad in patients with acute kidney injury. They can, in fact, be given safely and have been done so in some clinical trial settings. Fluid overload has many consequences in patients with acute kidney injury and is a risk factor for death. It's a risk factor for sepsis. I did not show you the data, but it can impact the ability to achieve appropriate antibiotic levels. I've shown you data that it can mask ascertainment of AKI itself and AKI severity. And finally, that managing fluids in patients with renal failure requires careful, individualized patient assessment. I'll stop there and thank you for your attention.